Hello, everyone. My name is Hidehiko Hara from Toho University, Ohashi Medical Center, Tokyo, Japan. Today, I'm going to talk about the Terminator Registry. So let me share with my slide here. So Terminator Registry was our first nationwide registry on the left atrial appendage closure and the transcatheter modification of left atrial appendage closure, left atrial appendage by obliteration with the device. So here are some background COS slides here. So the Terminator Registry was Terminator Registry demonstrated the real-world data on percutaneous left atrial appendage closure across Japan with the interventional cardiologists, as well as electrophysiologists and stroke doctors and echo physicians. So as you see, the left atrial appendage closure has been spreading worldwide to patients with non-valvular AFib. But in Japan, Watchman device introduced in 2019, and the Flex has been prevailing now, but there is a lack of the evidence on left atrial appendage closure in our country. So therefore, we began to conduct multi-center study to demonstrate the real-world data on the left atrial appendage closure. So here are the institutions included in this trial. And the primary efficacy endpoint were defined as death, ischemic stroke, and hemorrhagic stroke, and the sequelae from stroke, and the systemic embolization, and also device procedure-related event requiring surgery or intervention. And also the composite endpoint was defined with the ischemic stroke and the hemorrhagic stroke and the systemic embolization on the cardiovascular death. And the primary safety endpoint was defined a major bleeds and the clinical relevant bleeds, and also open heart surgery and or interventions, and also device embolization or DRT or catheter drainage for peripheral effusion, and or snaring of embolized device, and so on. And here you can see the patient characteristics, and the mean age was 74.9 years, and the majority of patients were male. And also the clinical frailty score was 3.4 on this cohort. And if you look at this slide, you can see the CHAS score was 3.2 and CHAS VASC was 4.7, and the heart split score was 3.4 in this trial. Here, we achieved the 98.9% of success rate, and that is quite similar with that of the evolution data here. And also, if you look at this procedure data, majority of patients received the general anesthesia, and also mean procedure time was less than 1 hour. And also, there are some reduced septal puncture or partial recap here. But if you look at the right side of the panel, you can see the tamponade was only 0.9%, and also the effusion was 1.1%. And the device migration was 0.3%, and there are some groin complications here. And here are some data with generation 2.5 and Flex. And if you look at the this data, more than half of the patient implanted the Watchman greater than 30 millimeter device, not only in generation 2.5, but also in a Flex device. So that means left atrial appendage of the Japanese cohort may be bigger than that of the Caucasian cohort in previous studies. And then if you look at this Kaplan-Meier curve, you can see the death from unknown cause. We saw 0.9% of deaths during the follow-up here. And here is a stroke data. And we saw 2.2% of stroke in the registry here. And 4 out of 16 patients complicated device-related traumas. But the stroke was quite not so significant. That means majority of stroke was modified ranking scale less than 2. And this is a bleeding event. So we saw 5.7% of the clinical relevant bleeds, and here is data from device-related thrombosis, and with a 2.7% of a DRT, and 4 out of 20 patients developed stroke, but all were modified ranking scale less than 2. And if we consider about the stroke according to the CHAS score, this cohort might have had the 8.0% of stroke without anticoagulation, but we achieved the just 2.8% of stroke. That means we achieved a 65% of relative risk reduction here. And when we consider about CHAS-VASc score, we saw the 67% of relative risk reduction in our cohort regarding stroke. But the bleeding events, we had the greater bleeding events than the theoretical bleeding events based on the Hasblet score here. In my conclusions, ladies and gentlemen, left atrial appendage closure real-world data in Japan demonstrated a high success rate with a low adverse event rate, and within 6 months follow-up data demonstrated a similar number of DRT and other adverse events comparing with other studies. Further investigation and long-term follow-up is mandatory to prove whether this local therapy would terminate cardioembolic stroke, as well as bleeding from anticoagulation that deteriorates patients' prognosis and the quality of remaining life. Thank you so much for your attention.
Hello, my name is Masaharu, Kyoto Medical Center. My COI. There were major changes in atrial fibrillation (AF) and oral anticoagulants (OAC) in the last decade. Warfarin was only available OAC 10 years ago, but the direct oral anticoagulants (DOAC) were launched for stroke prevention in patients with AF since 2011. In Japan, updated guidelines released in 2014 recommended DOAC as the first-line OAC therapy for AF patients. The Fushimi AF Registry is a community-based prospective survey to enroll all of the AF patients in Fushimi, Kyoto, Japan. The enrollment of patients was started in March 2011 and ended in May 2017, resulting in a total of 4,489 patients. Patient follow-up was completed in February 2022, and the longest follow-up was 10 years. We divided the entire cohort into 2 groups according to enrollment year, 2011 to 13 and 14 to 17, to compare the patient backgrounds and outcomes before and after the 2014 JCS guidelines. This slide shows clinical characteristics. The mean age was 73.6 years, and the patients older than 80 years consisted of 30%. Almost half of the patients were paroxysmal type. The mean body weight was 59 kg. Patients had various major comorbidities as shown in this table. The mean CHAS-2, CHAS-VASc, and Hasblet scores were 2.03, 3.37, and 1.75 respectively. This slide shows the year-by-year transition of antithrombotic therapy status from 2011 to 2021. The prescription of OAC gradually increased, and that of antiplatelet drugs (APD) decreased, along with the decrease of the combination therapy. In 2011, OAC was prescribed in 54%. 32% received APD, with 14% receiving combination therapy. In 2021, 69 patients, 9% received OAC, and 14% received APD with combination therapy, 7%. This slide shows the time trend of OAC therapy. The prescription of OAC gradually increased with growing proportion of DOAC. In 2011, warfarin was prescribed in 51%, while DOAC was given in only 2%. With steadily increasing trend of DOAC use, DOAC overtook warfarin in 2016. In 2021, 70% received OAC, warfarin 18% versus DOAC 52%. During the median follow-up period of 5.1 years, the annual incidence rates of events were all-cause deaths 4.9%, hospitalization for heart failure 3.2%, stroke or systemic embolism SE 2.2%, and major bleeding 1.9%. The event rates were generally lower in patients enrolled in 2014 to 17 than those enrolled in 2011 to 13. Despite that, the baseline characteristics were comparable with respect to age, CHES2, and Hasbret scores. All-cause deaths 5.0% versus 4.2%, stroke SC 2.3% versus 1.6%, and major bleeding 2.0% versus 1.6%. However, hospitalization for heart failure was higher in 2014 to 17 group, 3.1% versus 3.6%. This slide shows a comparison of event incidence according to OAC status. When compared with no OAC as a reference, warfarin use was associated with non-significantly higher incidence of stroke SE with hazard ratio 1.17, while significantly lower incidence in DOAC group, hazard ratio 0.69. Warfarin use was associated with significantly higher incidence of major bleeding with hazard ratio 1.32, while DOAC use was not, 0.99. In conclusion, during the last 10 years, there has been a major transition of antithrombotic therapy as well as a decline in incidences of adverse events in patients with AF. We appreciate all the participants of this registry. Thank you for your attention.
I am Dr. Kimura from Keio University. I am honored to present the results of the Apple Watch heart study. Two applications of Apple Watch, irregular heartbeat notification and the ECG application, have been approved as medical devices in Japan, allowing anyone to record an ECG on their arm anytime, anywhere. Now, physicians are expected to utilize these modalities for the early detection of atrial fibrillation. Apple Watch continues to monitor a pulse while you are wearing and may detect asymptomatic atrial fibrillation. However, because it is not a continuous monitoring, it may miss the timing to record an ECG. The question is, when should I record an ECG? The purpose of this study is to build an algorithm to answer this question. The study used a 2-week Holter ECG as a teaching data for atrial fibrillation. Atrial fibrillation was defined by a recording of more than 30 seconds and was confirmed by 2 experts. The study then compared the data between 3 different modalities: a transtelephonic monitor and Apple Watch. In addition, sleep shortage, excessive drinking, and increased stress are known to involve in atrial fibrillation attacks, but the degree varies from person to person. Using data that Apple Watch unconsciously collects, we aim to build an individualized risk stratification model. The objectives were to build a machine learning model to determine an optimal timing to record an ECG. It was also to investigate the relationship between the healthcare data and other clinical information. In order to achieve these objectives, we built the research application for the study to collect a huge amount of healthcare data. We designed the interface to keep the participants continuously engaged in the study for 2 weeks. The study participants were asked to wear an Apple Watch before sleep. The next morning, they were asked to answer several questionnaires. We also asked them to press the button if they had symptoms. The study population consisted of 100 patients with atrial fibrillation receiving treatment at our hospital. The average age was 64 years and the CHAT score was 0.9. Data of more than 1,000 days were available for evaluation. The number of atrial fibrillation attacks was approximately 2,000 events, or 38% as a burden. First, we analyzed the comparison of 3 modalities concerning the detection of atrial fibrillation. Comparing Apple Watch and a transtelephonic monitor, surprisingly, both specificity and a positive predictive value were 100%. These results indicated that two examinations had comparable characteristics. Our goal was to build a system that compensates for the limitations of non-contiguous monitors with the advantages of wearable devices. Then we analyzed the relationship between healthcare data collected by Apple Watch and atrial fibrillation. The number of steps was recorded as an amount of exercise. The average number of steps on the day before the atrial fibrillation attack was significantly higher than the day without attacks. This could be considered as one possible association between fatigue and the arrhythmic attack probability. Responses to the sleep questionnaire were categorized as well, normally, and insomnia. The number of wakings and the sleep period measured by Apple Watch showed significant differences between the groups. Further correlations between subjective data and healthcare data could be developed into a variety of other analyses. So far, we have identified healthcare data with direct involvement in atrial fibrillation attacks. Not only that, we have shown that it was possible to objectively evaluate subjective data using healthcare data. By considering these potential relationships, we are currently building a machine learning model so that we can provide personalized healthcare. We are also undergoing a nationwide Apple Watch heart study. The participants are targeted to all Apple Watch users in Japan. We will improve the model to optimize it for healthy people. We hope we can provide a personalized and sustainable medical digital transformation. We are all aware that the longer the recording, the better for detecting heart disease. Apple Watch can record ECGs anytime, anywhere. We will accumulate knowledge to maximize this usefulness and develop novel tools for early detection. At the same time, we have to determine whether all detected atrial fibrillation requires treatment, which is for doctors to decide, not for artificial intelligence. Thank you very much for your attention.